Hello guys, we are going into chapter 10, which is professional relatedness built on respect. So our objectives for today is understand trust and how to build it. Know the difference between transference and countertransference. You will need to understand that. Common mistakes in casualness, and learn respect, contract, and covenant. So the first slide here talks about building trust by being trustworthy. When we think about past medicine or medical models, we always would put our faith in whatever the physician said. We felt sick, we felt ill, we would go in, they would tell us what was wrong, and that's who we followed. It was that blind trust that we did. And we want to make sure that we're allowing our patients to feel that support and put their trust in us, that we know what we're doing. And that sort of shows respect for the people. In healthcare, trust is feeling safety, a comfort level, feeling that a patient can rely on a person with power not to hurt them, which is sort of hard in our field because we will make them uncomfortable at times, either by stretching them in an uncomfortable position, making them do transfers that's uncomfortable, or making them exercise that's making them sore, or things like that. And that is sort of hard in our field when we're trying to get our patients to trust us and we're actually hurting them. And that's why communication is so important for us. They need to trust us that we're actually getting them better and we're doing the correct things. The patient also needs to be convinced that we are seeing them as an entire person and not just a total shoulder or a total knee or a stroke. Like, we're seeing them as the whole picture and everything all together. And I know that I'm sure that you've sort of felt this experience when going to your own doctor, is you have to sort of put your trust in the doctor that they know what they're talking about. Competence and trust, we've already sort of touched base on competence, knowing what you know and are skilled to do. That is staying on top of research, not just being done with school and being finished, continuously looking up what's the new and best method for your patients. Being aware of personal and professional shortcomings. What do you struggle with? What is something that's hard for you? For me, I struggle with neuro. I always have. So I understand that. So when I have a neuro patient, I know that I have to work a little bit harder to make sure I'm understanding exactly what's going on. Some may not like to work with backs, or some may not like to work with peds, but understanding that and being aware of that is important for you professionally. And also being able to apply communication skills. All of that is important in your own field. Patients need to know, when they come in, they're going to need to know about their diagnosis, how it's going to affect them every day, and they're going to look to you for that, your skilled knowledge. Why do I have numbness? Why is my pain worse? Why is my numbness not gone? They're looking to you for that guidance and that you have the competence in the skills that you're doing, and they're going to trust you that you know how to answer their questions. They're going to trust you to know how to get rid of it too. Oops, sorry, I got ahead of myself. Let me go back. All right, so it's a little unfortunate. I can't switch. Once I start recording without like the little recording box of me, I can't switch it back. So I'm just going to give you some page numbers to look at. Through our actions, we demonstrate these expectations of how we are professionally capable of helping our patients. And we need to make sure that we are setting the proper example for our patients to see that. On page 194 of your book, there's a cartoon that has a doctor in a different room and like 3 patients sitting outside of that room. And the one patient looks like a toe, another looks like a femur, and another looks like a colon. And the doctor says, the toe and bone have arrived. Let's wait for the colon. And I know that in our field, I have seen it every single day, every clinic I've worked at, that we sort of do that. We go, okay, well, the right ankle sprain is here. the rotator cuff, and we do that so we don't break HIPAA, but at the same time, our patients want to be sure that they're not being looked at as just their diagnosis. So we just need to find a different way of approaching that option. Be an alert and active member of your healthcare team. Being aware of not just who's on your schedule, but the entire clinic. Now, this can be different depending on wherever you're working. If you're working at Arlington, there's 20 clinicians who work there, where there may be a clinic where it's just a PT and PTA. But being an active member of that team, making sure that you're aware of your surroundings, even if it's not your patient and a timer goes off, that you can go help them. You are able to do that. That's just working as a healthcare team member. And then find ways to advocate for your patients. That you are looking out for their well-being and that what's best for them. So if you find that the billing wasn't correct, or they need a different type of treatment or a referral, or if you think they need some type of equipment, actually advocating for your patients is building that trust in your patient, that patient believes that you are looking out for the best for them and not just money in your pocket. Honesty, reassurance, and trust. Assured, the definition of assured is to have a feeling of confidence and certainty. And reassurance is the action of removing someone's doubts or fears, a statement or comment that removes someone's doubts or fears. So being able to restore that feeling of losing that trust, I'm going to reassure you that I am doing the best that I can do for you. And you will constantly be reassuring your patients throughout their treatment. And they expect that honest reassurance from you. They expect it from every encounter that you're going through, that you are giving them the best, honest treatment, and that you are confident in your ability to heal them or not heal them, or give them the right answer, not making things up. Oh yeah, you'll get better. No, that doesn't always work that way, because not every patient is going to get better, and we know that in the field that we're in. Patients also expect that you are direct with them, that you are providing them with their diagnosis, their prognosis, and treatment decisions, and that you're not sort of going behind their back and just making things up. Remember, they are a part of the treatment process. If you are not making them part of the treatment process, the willingness of them to be active is going to decrease. So making sure that you are being upfront with your patient. Making sure that you understand that honesty and reassuring is giving information that you can stand behind 100%. That you can give without any mistakes in that information, and that you are certain that that information is correct. You will not be able to answer every question. No. But it is okay to answer it saying, I don't know that, but I'm going to look into that for you, and I will find the best answer I can. Also, being able to respond to some of those difficult questions. Well, can I go home? Sometimes you will have to say no. And that might increase the patient's anxiety, but being able to explain why will help help that patient understand. Use your own experience. I had a student who was in a severe car accident, who was in the hospital, who was in rehab, and he could use that experience in how rehab worked, how it looked, and that's going to help him. So use some of your own experiences. And some of the questions that you answer are going to increase your patient's anxiety, but there is a way that you can, again, reassure them that you are providing them with the best answer. There is a thing called transference and countertransference that you're going to need to know. Transference is coming from the patient to the therapist. Countertransference is the opposite. It's coming from the therapist to the patient. So transference is shifting your feeling about a person in your past to another person. This can be negative or positive. If it's a negative transference, the patient's confidence will be low and their guard will be up. If it's a positive, that promotes more of a well-working relationship. So if we think of an example of a negative transference, this patient has a therapist, and the patient thinks that the therapist sounds like their ex. That could be a negative transference. That would be, they might have their guard up. They may not want to be treated by you. A positive transference would be the patient has a therapist that looks like their grandmother. Well, I don't know. Or their aunt that they're really close with. That would be a positive transference. It can also go the opposite way, which is a counter transference. This is when it goes from the therapist to the patient. If I walk into my clinic and I'm treating my patient, and that patient is an ex-boyfriend who used to beat me, that would be a negative countertransference. It can be on a basis of name, physical appearance, voice, age, or gestures. Just understanding, and you need to be aware of these things that could happen. Recognize that these events do happen and that you need to be professional and work past them. So again, transference is from the patient, is thinking of the therapist as something positive or negative. Countertransference is when the therapist is doing it to a patient. Courtesy versus casualness. The definition of courtesy is courtly elegance and politeness of manners, graceful politeness or considerateness. This is sort of how you're being polite. Patients will see it from the second they walk in that door. Is how are you treating them? Are you holding the door? Are you helping them into a chair? Are you taking their coat and their purse and putting it in a safe place for them because they can't? All of these is courtesy, and patients pick up on these cues. The more that these cues are coming through, the better the work environment. It should be visible. They should be able to see that you're being courtesy. And again, they will pick up on it very, very quickly. So the next slide gives a few examples. Greeting them. Just a plain old saying, hi, how are you, is simple courtesy. Providing a safe place for their belongings. We didn't have any lockers in my clinic, so if I knew someone was carrying their purse around, the next time I would offer for them to put their purse back where my stuff was, so they felt a little bit more safer. No one was going to take it. Offering assistance around the clinic. Keeping them informed about any delays. Honoring their privacy. Providing reading material or other distractions. I had a few patients that like to have towels over their eyes when they would lay on their back, so the lights on the ceiling wouldn't get in their eyes. That's just a courtesy. It's something that I was kind and polite about. Rudeness is never, ever tolerated. And I'm not sure why I have to say that, but it's happened, surprisingly. But just making sure that you are going above and beyond for each patient. With that being said, we also need to be aware of informal casualness. It can be a sign of disrespect for the students. And I actually have... I've had a few instances with my students out on affiliation that were a little bit too informal, trying to be amusing, thinking that the patient should be having a fun time, and why aren't you having fun? This is therapy. They're not having fun. Some of them are in pain. They're uncomfortable, and that can be a sign that can make the patient upset if they're thinking that they should be having this grand old time and they're not. Establishing a first name basis too quickly. If they prefer Mr. Smith, then make sure you're calling them Mr. Smith and that you're not moving over to that first name basis without being appropriate. Telling the patient secrets that's of your personal nature. Your patients don't need to know about a divorce or that you got pulled over or arrested for a DUI. They don't need to know that kind of stuff. Your personal nature should stay at home. Does that cross over sometimes? It might. I've seen it with other clinicians, but for you professionally, it should be kept. Your personal nature stays at home. And then also regularly spending extra time with patient at another patient's expense. This is tricky because there are patients who just really like to talk and really like to enjoy your time. And there you have to sort of make a balance that each patient is getting an equal amount of time from each clinician or from you personally, that you're not spending more time with this patient because you like them and they're more friendly than with this other patient who's nasty and upset. You have to make sure that that's equal. So concentrating on care, really your care is just the concern about each patient's well-being. This is essential for you. I mean, this is your greatest definition. You care about your patients, and that's why you're doing what you're doing. Okay? It can be a challenge. It can be a burden. Really, if you do not care about your patients, you are in the wrong profession. Something that the book says is the ultimate goal of your daily work is to find the caring response to each patient situation. A response is behavior based on experience, reflection, and knowledge. A response is different than a reaction. The two elements that comprise all caring relationships is understanding the situation and a commitment to the good of another. So making sure that you are committed to each and every patient that walks through that door, whether they're friendly or not. Again, understanding the situation and commitment to the good of another are your two necessary elements for caring behavior. Understanding what's happening with your patient, listening to your patient, getting their full story, and then the commitment to making sure that you are caring and want that patient to be better than what they are now. Sometimes it can get a little confused because women may be devalued in this role because we are expected to always care because we're women. We should do that. So sometimes it's taken a little differently when males are in that caring role. It's seen as a little bit more affectionate, or a little bit higher because we should just be doing it. That still happens, but that doesn't mean that you shouldn't be doing it. Care is expected and not always appreciated. Again, I am sure we have all run into this situation where we've had some patients who didn't really appreciate the work that we were doing for them. That doesn't mean that we should make it any less. So the patient's perspective, the patient is going to have a deeper meaning of what's happening because it's happening to them. It's a personal meaning to that condition. They are the ones who can't walk. They are the ones who are in pain. They are the ones whose life has been altered due to what's happening to them. Where we are looked at it more objectively. We see their range of motion, their manual muscle testing, their edema, their swelling. So there's different perspectives on how we're looking at the patient. We think about that clinical condition and we need to take it and look at it in the aspect of their life. So yes, we look at it more objectively as of, okay, their range of motion is lacking, they're not strong enough, and they have swelling, but what is that doing? Well, they can't walk up the steps, they can't sleep long enough, and they're uncomfortable. So we have to think of it on more of a personal meaning for the patient and sometimes not so objectively. And again, we have to realize that there's a different connection between both of us. The patient's perspective on the condition is going to be different than our perspective on the condition. So any relationships includes dependence. And so making sure that you are teaching your patient how to maintain their own health. Again, I have said this before, the more active the patient is in their role, the more you're going to get back from that patient. If they want to know what's happening, how to fix it, they're active in their home exercise program, they're asking questions, these are going to help your patient and allowing them to understand that they're able to do some of these things on their own. That's going to encourage them to regain and remain healthy for themselves. The book does talk about respect, contract, and covenant. Decision making should be a shared process. We've already talked about the informed consent and how that looks, being able to share exactly what you expect them to do or what you expect this to happen and allowing them to make that decision. Don't allow patients to become discouraged. It becomes very easy for them, especially when you are thinking about what is actually happening with them. It can be challenging. But you will take that sort of leadership role in helping them get where they need to be. So that is chapter 10. If you have any questions, please feel free to email me. I am happy to help. Otherwise, I will talk to you soon for chapter 11.